Welcome back to the Deep Dive. Today, we are shifting gears just a little bit. We're getting very specific, very tactical, and honestly, a little bit intense.
I'd say so.
We're doing a dedicated session for our listeners out there preparing for their MD anesthesiology exams, specifically looking at the Gujarat University and D&B patterns.
It's a rite of passage, isn't it? And honestly, if there's one topic that really separates the prepared candidate from the one who's just, winging it,
It's obstetrics.
it's obstetrics. And within obstetrics, it is absolutely the topic we are covering today.
Exactly. We are tackling pregnancy-induced hypertension, or PIH, and we are not just skimming the surface here. We've pulled, well, a massive stack of resources for this one.
A proper staff.
We're talking the gold standard Miller's Anesthesia 10th edition. We've got Yao and Artuzio for that case management logic, objective anesthesia review for those crisp exam-friendly lists, and we've even got the actual DNB questions topic-wise bank going all the way back to 1995.
Which is crucial, because this isn't just about clinical knowledge. It's about how you present that knowledge to an examiner who's heard it 1,000 times before. So today, I'm not just going to be the analyst. I'm putting on my senior faculty hat.
I love it.
We are treating this like a proper mock prep session. Rigorous, precise, and focused on those high-yield points for the 20-mark answers and, of course, the Viva traps.
The mission is clear then. We need to give you, the listener, the structure for that big 20-mark question and the survival skills for any viva voce on PIH. So let's start with part A, the fundamentals.
Precisely. Because when you walk into that exam hall, you need to understand that PIH is a high-stakes game. It's a multi-system disorder that's just disguised as a simple blood pressure problem.
Yeah.
If you just treat the number and you ignore the underlying physiology, you fail. Simple as that. So let's get into it.
Okay, let's frame this for the exam. I'm sitting there, I open the paper, and the question is define and classify PIH, which, according to the question bank, has shown up multiple times. How do I start? What's the opening sentence?
You start with precision. You don't just say high BP in pregnancy. That's too simple. You state, according to sources like Miller, that PIH affects about 5 to 15% of all pregnancies.
Okay.
And you define it as hypertension that develops as a direct result of the gravid state. But then, and this is the key, you immediately pivot to the why. Why does this matter? You have to tell the examiner that this number is just a marker of a serious underlying pathology.
So it's the classic tip of the iceberg argument.
Exactly. You immediately state the risks. For the mother, the big three are cerebral hemorrhage, pulmonary edema, and coagulopathy. Miller is very clear on that.
And for the baby?
For the fetus, it's all about uteroplacental insufficiency and growth restriction. So right in your opening statement, you've established that you know the stakes are high on both sides of the placenta. You say PIH is a leading cause of maternal mortality and morbidity worldwide. That sets the gravity for your whole answer.
Okay, that makes sense. Let's move to classification. This feels like a place where examiners can really trip you up with terminology. How do we keep it strict and clear?
You stick to the standard classification. Just visualize 4 main buckets. First, you have gestational hypertension.
Okay.
This is new onset hypertension.
Yeah.
So systolic over 140 or diastolic over 90 appearing after 20 weeks of gestation. But, and this is the crucial part, it's without proteinuria or any other systemic findings.
So at that point, it's really just a number.
Right. It's a warning shot. It's usually benign. It often resolves after delivery, but it tells you to pay close attention.
Got it. What's bucket number 2?
Preeclampsia. This is the big one. And you have to be very specific with the language. We don't really say mild and severe anymore. The correct terminology is preeclampsia without severe features and preeclampsia with severe features.
And what's the dividing line?
Preeclampsia is that hypertension after 20 weeks plus proteinuria, or if there's no proteinuria, you have hypertension plus one of the severe features, things like low platelets, renal insufficiency, impaired liver function, pulmonary edema, or those telltale cerebral symptoms.
Okay, and the third one?
Eclampsia. This is the end stage you're trying to prevent at all costs. Eclampsia is defined very simply. It's the onset of new grand mal seizures in a patient who already has preeclampsia. It's a full-blown neurological crisis.
The failure of cerebral autoregulation.
Precisely. And the fourth bucket.
Chronic hypertension.
Right, the patient who had high blood pressure before she even got pregnant, or it was diagnosed before 20 weeks. But here is the very high-yield exam tip. There is a critical subgroup here.
Let me guess. This sounds like a Viva trap.
It absolutely is. It's called chronic hypertension with superimposed preeclampsia.
So a patient who already had hypertension and now things are getting worse.
Exactly. If that patient suddenly develops new proteinuria, or her blood pressure shoots up and becomes uncontrollable, or she develops any of those severe features we just talked about, low platelets, high liver enzymes, she has crossed over into this much more dangerous category. Examiners love this because the prognosis is far worse than either condition alone.
Got it. So that's the framework. Now, let's move to Part B, pathophysiology. For that 20-mark answer, I need to explain the why. The sources seem to point to a few core theories.
They do, and you need to present them clearly. You can break it down into three main theories. Number one is vasospasm. For some reason, the vascular smooth muscle becomes abnormally sensitive to circulating catecholamines and angiotensin II.
So the blood vessels just clamp down way harder than they should.
Way harder. The second theory is immunological. There seems to be an antigen-antibody reaction happening between fetal and maternal tissues. The mother's body is, in a way, rejecting the placental invasion.
So the spiral arteries don't remodel properly.
Exactly. Instead of becoming these beautiful, low-resistance, high-flow vessels that can nourish the placenta, they stay narrow and constricted.
Which leads to ischemia.
Correct. But the third theory is probably the most, let's say, exam-friendly mechanism to explain. It's the prostaglandin imbalance.
Ah, this is the classic thromboxane versus prostacyclin battle, isn't it?
It is. In a normal, healthy pregnancy, you have plenty of prostacyclin. It's a vasodilator. It keeps platelets from getting sticky. In PIH, the balance tips. You get a huge surge in thromboxane A2, which is a potent vasoconstrictor and a platelet aggregator.
And that imbalance leads to the central problem.
The central problem: widespread endothelial dysfunction.
That phrase seems to be the key that unlocks this whole systemic collapse.
It is the key, because the endothelium lines everything. When it gets damaged, it becomes leaky. You get this combination of increased systemic vascular resistance, or SVR, because of the vasospasm, but you also get reduced intravascular volume because fluid is leaking out of the vessels and into the tissue.
Which creates that classic paradox that the textbooks always mention.
You say it.
Edema with hypovolemia.
That is the phrase that gets you the marks. The patient looks puffy, she's swollen, so your first instinct might be she has too much fluid. But inside her blood vessels, she's dry. She's hypovolemic, and that's a critical management point.
Because if you diurese her, you could crash her perfusion.
You'll crash her perfusion, and you'll starve the baby of oxygen. This directly connects to the systemic effects.
Okay, let's break this down by organ system. This is a classic short note question. Let's start with the CNS, the brain.
The CNS is the danger zone. The warning signs you're looking for are an altered mental state, severe headaches, usually frontal and visual disturbances, things like blurred vision or scotomata, those flashing lights.
And on examination.
Hyperreflexia and clonus, those are signs of cerebral irritability. The ultimate risk here is cerebral edema and hemorrhage. The high pressure literally breaks through the blood-brain barrier.
Scary stuff. Cardiovascular.
Well, we've already talked about the high SVR. That puts a huge afterload on the heart. The left ventricle has to pump against incredible resistance if it starts to fail, or if those leaky capillaries in the lungs get overwhelmed with fluid.
You get pulmonary edema.
You get pulmonary edema, a very common cause of death in these patients.
Okay, what about the renal system? Proteinuria is the hallmark sign.
It is. What's happening is something called glomerular endotheliosis. Essentially, the filter in the kidney gets clogged and leaky, so your GFR drops, and you start losing massive amounts of protein, specifically albumin in the urine.
Is there a number to watch for creatinine?
Yes, if the serum creatinine goes above 0.09 millimol-L, that's a big red flag. You have to remember, creatinine is usually low in pregnancy because of hyperfiltration. So a normal creatinine level in a pregnant patient can actually be a sign of renal failure.
And the liver. I read about a very specific symptom.
Yes, and you must know this for your clinicals. Severe epigastric or right upper quadrant pain. This is not heartburn.
Right.
This is the liver capsule stretching because of edema or a subcapsular hemorrhage. If a pregnant woman with high blood pressure complains of that specific pain, you have to worry about her liver rupturing. That is a surgical catastrophe.
That's terrifying. Okay, hematological.
Thrombocytopenia. Low platelets. This is absolutely critical for us as anesthetists, isn't it? Because it dictates whether we can safely put a needle in her back for regional anesthesia. You also have to worry about DIC, disseminated intravascular coagulation, where the clotting cascade goes haywire.
And we can't forget the passenger in all this, the fetal effects.
It all comes down to supply and demand. The uteroplacental insufficiency means the baby is starving for oxygen and nutrients. You get intrauterine growth restriction, IUGR, and oligohydramnios, which is low amniotic fluid. This is why these babies often don't tolerate labor very well.
And they end up as emergency C-sections.
Frequently.
Okay, so we've built the beast, now we have to tame it. Part C, anesthetic management. Let's start with a preoperative assessment. You're walking into the room to see this patient. What's on your checklist?
It's a mental checklist. First, airway. I assume a difficult airway, period. The mucosal edema isn't just in her ankles, it's in her larynx, her pharynx, everywhere. Her Malin-Patty class can change literally during labor.
So you're already thinking about using a smaller tube.
Absolutely. I'm thinking smaller tube, and I'm thinking videolaryngoscope. Second on the list, BP control. I need a baseline. If her systolic is over 160 or diastolic is over 110, we have to treat that acutely. We cannot proceed with anesthesia until that pressure's down. She is at imminent risk of a stroke.
And then coagulation.
I need a platelet count. And not just one number. I want to see the trend. Is it stable or is it plummeting? If it's below 100,000, I'm getting nervous. If it's below 75,000 or 80,000, depending on your hospital's policy, regional is likely off the table.
Okay, let's talk about getting that blood pressure down. Antihypertensive drugs. This is a clear exam favorite. What's in our toolbox for an acute situation?
For acute management, labetalol is the workhorse. It's a combined alpha and beta blocker. The dose is usually 5 to 10 milligrams FAB, given every 10 minutes or so. It's great because it lowers the pressure without compromising placental blood flow.
What about methyl-dopa? I see that listed a lot.
Metyl-dopa is for chronic management. It's an outpatient drug. It works centrally, but it takes 24 to 48 hours to really kick in. It's completely useless in a hypertensive emergency on the labor ward.
Okay, hydralazine.
Still used, though probably less so than labetalol now. It's a direct arteriolar vasodilator. The dose is 5 milligrams, the FIFE. The catch with hydralazine is that it can cause a reflex tachycardia, which might not be ideal, and it can take 20 minutes to peak, so you have to be careful not to stack the doses too quickly or you'll cause profound hypotension.
Now, there's a really specific warning I saw about nifedipine.
Yes. And listen to me very, very closely on this. This is a major safety point for your exam. Do not ever say you will use the bite and swallow or sublingual technique for nifedipine.
Why not?
Because it causes a precipitous, uncontrolled drop in blood pressure. It can cause a stroke in the mother and crash the fetal heart rate. You can use oral nifedipine, swallowed whole, but never, ever sublingual in this context. It's a fail point.
Good to know. Okay, let's talk about the drug everyone associates with this condition. Magnesium sulfate.
Absolutely essential. But the first thing you say to the examiner is you must clarify the indication. We do not give magnesium primarily to lower blood pressure.
Right.
It is a mild vasodilator, yes, but its main purpose is to prevent and treat eclamptic seizures. It's a membrane stabilizer and a CNS depressant.
The question banks often ask for the specific regimens.
You need to know the names. There's the Pritchard regimen, which is the intramuscular one, and then there's the Zuspan regimen, which is the intravenous one we use more commonly now. That's a 4-gram loading dose over about 20 minutes, followed by a 1 to 2 gram per hour infusion.
And what about toxicity? That's a classic Viva question, isn't it? How do you know if you've given too much?
It is, and you have a simple 3-step answer. First, you monitor the deep tendon reflexes. The patellar reflex is the first one to disappear. If you lose the reflexes, you start the infusion. Second is respiratory rate. At higher levels, it causes respiratory depression. And third is urine output. Magnesium is cleared by the kidneys. If the patient develops renal failure, which we know can happen in PIH, the magnesium levels will skyrocket to toxic levels very quickly.
And there's a specific drug interaction we need to know about as anesthetists.
A critical one. Magnesium potentiates non-depolarizing muscle relaxants. It inhibits the release of acetylcholine at the neuromuscular junction.
So your rocuronium or vecuronium will last much longer.
Much, much longer. You have to reduce your dose, and you absolutely must use a peripheral nerve stimulator to confirm recovery before you even think about extubating the patient.
Okay, let's move on to Part D, anesthesia for delivery. This is the big decision point. Regional or general?
The preferred technique, when it's safe to do so, is regional. Specifically, an epidural is considered excellent.
Why an epidural over spinal?
Because it's titratable. You can bring the block up very slowly and gently, which avoids sudden dramatic drops in blood pressure. Plus, the sympathetic block it provides can actually reduce circulating catecholamines and improve blood flow to the placenta.
But a spinal is much faster, which is often needed in obstetrics.
It is faster, But a spinal causes a rapid, dense sympathectomy. In a PIH patient who is already clamped down and intravascularly dry, a spinal can cause the bottom to completely fall out of their blood pressure. It can be very dangerous if not managed proactively.
And if you do get hypotension, what's the vasopressor of choice?
The modern answer is phenylephrine. We used to use ephedrine, but studies show phenylephrine is associated with less fetal acidosis. So phenylephrine is the drug you want to mention.
And what's the absolute hard stop for doing any kind of regional technique?
Coagulopathy, specifically low platelets. If the platelet count is too low, or if the patient has other signs of a coagulopathy, you cannot risk putting a needle in their back. The risk of an epidural hematoma, while rare, is devastating.
Which forces your hand to general anesthesia.
It does.
So let's talk about that. GA and PIH. Why is this considered such an exam favorite?
Because it is fraught with risk. It tests your ability to manage a crisis. The two big risks you have to discuss are, 1, the difficult airway we've already mentioned, and 2, the exaggerated pressor response to laryngoscopy.
The hypertensive surge.
Exactly. You take a patient whose baseline blood pressure is 180/110 and you put a laryngoscope in their throat. That stimulus can cause their systolic pressure to spike to 250 or even higher.
Which can cause a stroke right there on the table.
It can cause an intracranial hemorrhage. You must blunt that response.
How do you do that? What are the strategies?
You have several options. You can give a bolus of IV labetalol or esmolol right before induction. Lidocaine can also be effective. Some people use short-acting opioids like remifentanil or fentanyl, but you have to be mindful of the effect on the baby. The principle is you have to deepen the plane of anesthesia or block that sympathetic surge before the tube goes in.
And what about the tube itself?
Size down, always size down. The glottis will be swollen and edematous. If you would normally use a 7.0 tube, have a 6.5 and a 6.0 ready to go, and have the difficult airway cart in the room. Have the videolar endoscope ready. You treat every PIH airway as a potentially difficult airway until proven otherwise.
Okay, worst case scenario. The patient is actively eclamptic. She's seizing, and the baby needs to come out now. What's the protocol?
This is a classic question. Management of emergency LSCS in eclampsia. Your first priority is not the surgery, it's control the seizures.
You can't operate on a seizing patient.
No, you give magnesium. That's the first-line drug. If that fails, you can use a small dose of a benzodiazepine or thiopentone. Priority number 2 is airway protection. Seizing patients are at huge risk of vomiting and aspirating. If she's seizing, she needs to be intubated to protect her airway. Only then, once the seizures are controlled and the airway is secure, can you proceed with the C-section.
And after delivery?
Straight to the ICU. She'll likely need to remain intubated and ventilated until she is neurologically stable and the seizures are fully controlled.
Okay, let's shift to the intraoperative and postoperative phase, Part E. We touched on fluids earlier, but let's reinforce it.
It needs reinforcing. The strategy is restrictive. The biggest mistake a student can make in an exam is to say, I'll give a fluid bolus of 2 liters.
Because you'll drown her lungs.
You will absolutely drown her. Her colloid oncotic pressure is low because she's losing albumin in her urine. The capillaries are leaky. Any excess fluid you give her will go straight into her lungs. You titrate fluids very, very carefully against her urine output and her clinical status.
What about uterotonics? After the baby's delivered, we need the uterus to contract. Usually we give oxytocin, but also ergometrine.
This is a major, major safety point. You must say in your answer that you will avoid ergometrine or methergine.
Why?
It's a potent vasoconstrictor. In a patient who is already severely hypertensive, giving ergometrine can precipitate a catastrophic hypertensive crisis, a stroke, or a myocardial infarction. It's contraindicated.
So what do you use?
You use oxytocin, but you use it as a slow infusion, not a rapid IV bolus, which can cause hypotension. If you need a second-line agent, carboperost is a safer alternative.
Okay. Post-op. The baby is out, surgery is over. Is the danger over?
Absolutely not. In fact, the hypertension often peaks in the first 24 to 48 hours post-delivery as fluid mobilizes back into the vascular space and catecholamines surge. The postpartum period is a very high-risk time.
So they need close monitoring.
They need high-dependency or ICU-level monitoring for at least 24 hours. And you must continue the magnesium sulphate infusion for 24 hours post-delivery to prevent postpartum eclampsia.
And for pain management.
Good pain control is key to prevent hypertension, but you should avoid NSIs if there's any evidence of renal impairment or if the platelets are low. Multimodal analgesia, perhaps with an epidural if one was placed, is ideal.
Okay, let's pull all this together into Part F exam integration. Let's talk about the complications that often appear as short notes. First up, HELLP syndrome.
HELLP is an acronym. You must define it. H for hemolysis, EL for elevated liver enzymes, LFP for low platelets. It's a severe variant of preeclampsia.
And the key anesthetic implication.
Almost always the low platelets. If the platelet count is falling rapidly, regional anesthesia is extremely dangerous. You're likely looking at a general anesthetic, and you need to have blood products available in the operating room.
Pulmonary edema.
We've covered this, but to summarize, it's caused by that toxic combination of fluid overload, high cardiac afterload, and leaky capillaries. The management is to sit them up, give them oxygen, and use diuretics like furosemide, but very cautiously.
Yeah, I see.
Disseminated intravascular coagulation. This can be triggered by the endothelial damage, or often by an abruptio placenta, which is more common in women with severe PIH. It's a consumptive coagulopathy. You need to activate your hospital's massive transfusion protocol.
All right, now for my favorite part, the common exam questions and Viva traps. You mentioned a specific trap about the safe triangle.
Yes, and this is a great point from the source material. Sometimes students, trying to sound smart, will mention Cambin's triangle when asked about the anatomy for placing an epidural.
Sounds impressive.
It does, but it's completely wrong. Cambin's triangle is an anatomical landmark for minimally invasive spine surgery. It has absolutely nothing to do with neuraxial anesthesia. If you say that in an obstetrics viva, the examiner will know you're just repeating buzzwords you don't understand.
So stick to the basics. Midline, paramedian.
Stick to what you actually know. Trap number 2, fluid loading.
We've hit this hard, but let's say it again.
Do not say, I will preload with 1 liter of crystalloid. You say, I will co-load carefully, or I will use titrated fluid administration. Showing you understand the risk of pulmonary edema is a pass. Ignoring it is a fail.
The knife to peen route.
Never, ever say bite and swallow or sublingual. Oral route only, with the caveat about the risk of precipitous hypotension.
And trap number 4, magnesium toxicity. The patient's reflexes are gone. What is the immediate answer?
Stop the magnesium infusion and give calcium gluconate. That's the antidote. You need to say that immediately.
Okay, let's talk presentation. For that 20-mark long answer, how do I structure it on the page to make it easy for the examiner to read and grade?
Visuals are your friend. Start with your definition. Then immediately draw the classification table. Don't write it out as a long paragraph. Use a simple table. It's clean, it's quick, and it shows you're organized.
And for pathophysiology?
Draw the pathophysiology flowchart. Show the progression. Abnormal placentation leads to endothelial injury, which leads to vasospasm and platelet aggregation, which leads to multisystem organ damage. It tells the whole story in one picture. Then, for management, use a management algorithm format. Pre-op, intra-op, post-op. Use headings and bullet points. Make it easy to award you marks.
Okay, let's wrap this up. We need a final high-yield summary for the listener. The bullet points that should be flashing in their mind as they walk into the exam.
Here is your final checklist, your take-home points for the exam.
Go for it.
1. PIH is a multisystem disorder, not just high BP. 2. The airway is swollen, always size down your ATT. Think 6.0 or 6.5. 3. Regional is preferred, but platelets dictate safety. A count below 75,000 is very risky. 4. You must control the blood pressure before induction to prevent a stroke. 5. Magnesium is for seizure prophylaxis, not for blood pressure, and you monitor the reflexes. 6. Fluid restriction is absolutely key to avoiding pulmonary edema. 7. Avoid ergometrine. And 8. Post-op monitoring for at least 24 hours is mandatory.
That is an incredibly solid list.
And I'll leave you with one final thought. The examiner's main goal is to determine if you are a safe practitioner. If you demonstrate through your answer that you are prioritizing maternal safety, protecting the airway, preventing the stroke, avoiding the drug errors, you will pass. Don't try to be a hero with obscure facts. Just be safe.
Airway BP coagulation, that really is the triad to keep in your head.
It is. So good luck with the MD exams. You've done the reading. Now you just need to structure the answer.
And to everyone listening, thanks for joining us on this deep dive. We will catch you on the next one.
You've got this.